Great. Welcome, everyone. I'm Adelina Comas-Herrera from the Global Observatory of Long-Term Care at the London School of Economics. I'm really delighted to welcome you all. I'll give a very, very brief presentation just so you know a bit more about the observatory in case you didn't, and also so you're aware of our next webinars as well. The Global Observatory of Long-Term Care is a platform for cross-national learning on long-term care. We're working to identify key shared long-term care challenges, showcase how countries and localities are addressing them, sharing research evidence, and facilitating collaborations. And this is for everyone from policymakers, industry advocates, care professionals, and academics. And this is part of the International Long-Term Care Policy Network and based at the London School of Economics. And in case you aren't a member yet, I really encourage you to become a member because that's how you really get into the action. And here we have the link. And I know that my colleague from GOLTC NAS will be putting the link on the chat as well. And this is a way in which you can share your knowledge. You can find people with similar interests because you select the interests you have. You can share your publications and events. You can always let us know when you have a new paper that's really good. We now have a blog, so we can also publish blog posts where you can announce and discuss your new research. And you can, of course, also subscribe to the newsletter. Our next webinar after this one is on Tuesday next week, and we're going to hear about the structural characteristics of long-term care facilities and COVID mortality in Sweden. And there are some important lessons from this for care home markets and regulation, and this is part of the care home markets and regulation interest group. We then have one in collaboration with WHO Europe and the European Commission on a state of long-term care assessment that's being developed and piloted in 3 countries. We're going to hear, or 2 countries, I think. We're going to hear from Ireland and Greece. And yeah, Cassandra will also be part of that, who's one of the members of the Economics of Long-Term Care team. We then have one in Spanish. We have a long-term care in Spain interest group. This is the first country-specific interest group, and their first meeting is on the 15th of July, but it is in Spanish. You can, of course, join even if you just want to listen in to practice your Spanish. But the focus here is about research on long-term care in Spain and policy. And on the 23rd of July, we have one on the hospitalization outcomes of people who have been in care homes or receiving home-based long-term care. This is using quasi-experimental methods. I think it's differences in differences, and the presenter is Katia Nicodemo. So I hope you'll find that some of these are of interest. There'll be also future webinars of the Economics of Long-Term Care interest group. And I'm delighted to hand over to the members of the steering group of the Economics and Long-Term Care interest group. Thank you.
Thank you, Adelina. Hello, everyone. Thank you for joining us today. Let me just briefly introduce our interest group. Okay, so in the Economics of Long-Term Care interest group, actually, we try to bring together the health and social care researchers, policymakers, and practitioners who has got an interest in economic evaluation approaches or financing of community-based long-term cares, and also measuring the impact of long-term care policies. So here we try to be focused more on the social care and community-based intervention in response to the needs of the aging population, rather than being focused on the clinical aspect. So, and the impact that these conditions has on the patients, their families, and also the broader society. And we aim to develop the methodological aspects of the measuring for value of money and financing mechanisms, as well as impact assessment in this context. So we have got 4 steering members, including myself. So I'm proud to introduce our colleagues in this interest group. Cassandra Simons, who is the technical advisor for long-term care in the WHO regional office right now. And she has got a master's degree in economics and previously has worked with the European Center for Social Welfare Policy and Research with a focus on the financing of long-term care, quality of care, and informal caregiving as well. Dr. Elizabeth Lemon, who is not with us, unfortunately, today. She wasn't feeling very well to attend. So she has got a PhD in economics from the University of Stirling, and she is currently working in the University of Edinburgh with extensive research experiences in the economics of aging, home cares, and long-term care. So then it's me. I'm Sedighe. I'm working in the Population Health Institute of Newcastle University. I'm a health economist. I have also got interest in the economic evaluation of long-term care with a focus on aging and mental health. So we have also Professor Courtney Van Houtven in our steering committee. She is a professor in the University of Duke University in USA, and she has been a health economics and health service researcher since 2013 there. Dr. Van Houtven is also a research career scientist in the Center of Innovation to accelerate discovery and practice transformation, ADAPT, in Durham Veteran Affairs healthcare system in US. Dr. Van Houtven has also got an extensive research interest and experience in economics and in evaluation of long-term care, unpaid care, and community-based care. And she's also going to present today as well for us. So within this interest group, we try to bring together experts from different parts of the world, different specialties to organize these regular webinars. Today is the second webinar that we have, and we are going to plan also at least another webinar for this year. So you can check the link here to just check out the interest group and see our update there. So for today's presentation, as I said, Professor Van Houtven is going to present on the economic cost of informal care and policy solution to optimize the long-term care at home. As well as Professor Norma Coe from the University of Pennsylvania, who I'm proud to introduce. Professor Coe is Associate Professor of Medical Ethics and Health Policy at Perelman School of Medicine, University of Pennsylvania. She has got a research interest in health economics and public finance with a focus on causal effects of policies on human behavior, health, and healthcare utilization. So Professor Coe is also the co-director of the Population Aging Research Center and also director of the research on Leonard Davis Institute of Health Economics. The topic that she's going to present today is one of the interesting research pieces with her colleague on home-based care and patient outcomes. So just a little bit housekeeping. We will have like around 20 minutes presentation by Professor Coe, followed by around 15 minutes presentation by Professor Van Houtven. After that, we will have the question and answer section. Unfortunately, Elizabeth is not here today, so I'm going to lead the question and answer section. You can raise your hand or just use the chat function to ask your question. You can also use the chat function to actually introduce yourself as well. So after that, we will have like a short discussion on the economics of long-term care interest group itself, led by my colleague Cassandra Simons. Okay, thank you everyone. I'm just going to hand over to Norma. If you could please just share your slides.
I see them well, thank you.
Thanks so much for having me. It's such a pleasure to see some familiar names and faces. Looking forward to meet more of you. This is work with Courtney, who you'll be hearing from next, as well as Tamara Kaneska, Shushwan's son, and Anirban Basu. And I have to thank the NIH for funding this work, and the normal disclosures apply. This is our views, not the views of the National Institutes on Aging. So first, there was the motivation. So this was just a simple descriptive statistics that we ran looking at the health and retirement study. This is all pre-pandemic data, looking at how the home care delivery teams have changed in the United States. There's been a lot of reasons why these things might be changing, but we just wanted to see, okay, so what is happening over time? The good news is that we did find among people living at home who have limitations in activities of daily living or instrumental activities of daily living, we do see a decrease in the number of people receiving no care. Those are the sort of shrinking red boxes. That's presumably a good thing. But we don't see huge changes or decreases in informal care or family care, which was one thing that people have worried about as demographics have changed and where people live has changed. There was some concern that, as we increase formal care coverage, as we have in the US with home and community-based services and Medicaid, and we do see increases in formal care receipt, there isn't a sort of crowding out of any informal care. What we do see is sort of these rising blue boxes. So more and more people are receiving both family care and formal care, and fewer people receiving no care. So again, increasing access of care, so that's probably a good thing. And then our question really was, does it matter, right? So if we see these shifts in who's providing care, what does that mean for the patient outcomes? And so first we ran a systematic literature review, and there was a lot of papers that really look at the correlation between the care delivery team, a lot of papers looking at the correlation between care delivery team and patient outcomes. But there's a lot of concern that, well, the care delivery team may be determined by sort of underlying health characteristics. You can easily imagine a case where someone has their adult daughter taking care of them until they're so sick that they need to bring in extra help. And so there was a few papers that looked at the causal relationship between the care delivery team and patient outcomes. These are some of them here. And they do seem to find some differences in health based on who's providing care. So for the Barnett paper, they found that the risk of depression changes whether or not they have informal care versus formal care. And informal care, interestingly enough, it was a difference in time horizon. So family care or informal care reduces the risk of depression over the long term, but formal care had a more immediate impact within the last month. In earlier work, almost the exact same team, we found that using data from the early 1990s in the US, that adding informal care actually reduces healthcare utilization and improves physical health in terms of bed sores and infections among a very sick cohort of individuals that were eligible for Medicaid. And then there's some more mixed work focusing on ADRD patients or dementia people living with dementia that it may not change functional status, but may change where people live. So what we did in this paper is we wanted to look at people living in the community. So people are sort of eligible for community-based care. We're looking at the health and retirement study. This is all pre-pandemic data, so 2022 to 2018. They have to report having some sort of activity of daily living or instrumental activity of daily living limitation. And then we also limited the sample to people who are receiving some type of home-based care. It didn't seem fair to kind of compare to people receiving none. So we wanted to really look at among people who are receiving care at home, does the team matter? Presumably receiving some is probably better than receiving none in most cases. So there's different ways in the HRS to identify informal or family care and formal or paid care. First is basically once you report you're having an ADL or an IADL limitation, they then ask who helps you with it. You can go through the helper file and identify whether or not that person is related to you and whether or not that person is paid. So that's how we differentiate between the informal or unpaid helper and the formal or the paid helper. There's another part in the survey where they also ask whether or not a medically trained person has come to your home. We use that in our baseline definition of formal care, but our results are not sensitive to whether or not we drop that part of the definition. And so those are our definitions. The treatment variable is a three-pronged. So you can be receiving family care or informal care only, formal care only, or both at time T. And then we're looking at outcomes 2 years later, because that's when the health and retirement studies intervals are. And we look at self-reported good to excellent health. We look at positive aspect, depression, and mobility. And then we have a lot of different controls that we can use. We want to control for baseline health characteristics, control for socioeconomic status. Because in the US, we don't have comprehensive long-term care insurance, we add controls for receiving Medicaid, which is where you can get public long-term care insurance in the US, or having a private long-term care insurance plan. And we also include year and state fixed effects, because Medicaid policy is driven at the state level in the US. And so there's a lot of variation in Medicaid policy. And so we wanted to control for that. So we add state fixed effects for that. But as I mentioned, right, we're concerned about endogeneity because healthier people may rely more on informal care, and sort of as people progress, you can understand, or it's feasible to think that the care team changes the more disabled or more care you might need. So what we rely on is an instrumental variables approach. We look at the number of children. So as an older adult, the number of that has physical limitations. I look at how many children I have. They're all adults, probably in their 50s. And then I also look at the number of siblings that I have. So, you know, my sisters, my brothers, and does the family structure on my generation and the family structure in the generation below me, does it influence the long-term care team? We have mostly binary outcomes. We have endogenous variables and instruments. And so instead of running a two-stage least squares approach, we actually use a two-stage residual inclusion approach with generalized residuals. This is how it's done. The main sort of difference in interpretation is that using a two-stage RI approach will give us an average treatment effect, not a local average treatment effect. So just to keep that in mind. All right, so here's some descriptive statistics. Hopefully those numbers are big enough that you can read on your screen. So just so you're a little bit aware of what we're looking at. So 2/3 are receiving family care only, 14% are receiving formal care only, and 20% are receiving both types of care in our sample. And then I've also highlighted some of the differences in the distributions on the descriptive statistics that might be of interest. So if you're white, you're disproportionately more likely to be receiving formal care only. Black and African-American in our sample are more likely to be disproportionately more likely to be receiving both family care and formal care. And other races and Hispanics individuals in our sample are more likely to be receiving family care only. The marital status correlations are as you'd anticipate. So if you're currently married as an older adult with disabilities, more likely to be receiving formal care, and divorced and widows are more likely to be receiving, family care. Divorced and widowed individuals are more likely to be receiving formal care, and for widows, more likely to be receiving both formal care and family care. As I mentioned, sort of the wealth distribution has a lot to do with your access to long-term care insurance through the Medicaid program. And so you do see more people in the lower wealth distributions using both types of care. That could be the Medicaid effect. It could be that being sick for so long has led you to be down in the lower wealth quintiles. And if you're the highest wealth quintile, you're more likely to be paying for it and have formal care only. this is the sort of things we were most concerned about, is sort of your baseline health characteristics are much more likely, the more limitations you have, the more likely you're going to be receiving both types of care. And I already mentioned that's sort of covered by Medicaid effect. These are slightly, for the US standards at least now, this is sort of slightly bigger families than average. We do limit it to people who do have children. Or no, actually, sorry, I take that back. We don't do that. So on average, they have a number of 3 siblings and just over an average of 3 children. So slightly bigger than current cohorts here in the US. And you do see differences in distributions of children and the types of care. As far as outcomes, the biggest one we see, there's actually relatively, they're relatively flat between the different types of care. I think probably the biggest one is mobility. Again, as expected, people who have low mobility are more likely to be receiving both types of care. Interestingly, I thought at least there's a correlation between good health and formal care only. Depression is pretty even, positive affect is pretty even. All right, so here's our first stage. So this is just predicting what type of care you are, long-term care you're receiving in your home. So we're trying to predict, sorry, I didn't mean to get that going there to cover the screen, but trying to predict formal care only or both types of care, with informal care being the default or the reference group. And what we find is that sort of the number of children negatively predicts receiving formal care only, very consistent with previous literature, that having a lot of children or having more children or having more female children increases the chances of receiving family care. And what we find for receiving both is actually the number of siblings decreases the probability of receiving both types of care. I think the argument is very similar. Sort of the idea is that the more potential informal caregivers you have or family caregivers you have, the less likely you're going to be relying on formal care. And so these all pass the traditional tests of having F-stats of over 10. Which leads us to go straight to our primary results. So this first panel A is really just the correlation. So that's just the regular regressions on the relationship between care provision and our different outcomes across the different columns. I was kind of surprised here. We actually don't see a lot of just sort of raw correlation in our data set. So we don't see sort of massive effects that having both types of care is related to worse health outcomes. We do see that for the mobility scale as we anticipated, but not necessarily across the board. When we move to panel B, that's where we get into our causal methods and our causal results. And we do start seeing some effects once we move to the IV model. And so we found that formal care only is less likely to have people receiving formal care only or less likely to have positive affect or sort of positive outlook on life. So this is actually sort of a worse outcome with the way positive affect is scored than people receiving family care only. And those receiving family and formal care have better self-rated health and lower depression as measured by the CESD-8 compared to those who are receiving family care only. So there does kind of seem to be a little bit of a hierarchy here where, family and formal care seems to be sort of that yielding better, both physical, at least self-rated physical and mental health outcomes. We have done a lot of sensitivity analysis. We tried different instruments and different combinations of the instruments, breaking down not just the number of children, but also the gender distribution of the children and the siblings. Again, because we're looking at using two-stage residual inclusion and not doing lates, our average treatment effects are actually almost identical when we change the instruments. We examine individuals that don't have spouses with the concern that it's really hard to measure what spouses are doing, if it's really informal care or if it's just being married together and living together. And again, our average treatment effects are almost identical. When we limit the definition of paid family care to only include that first set where it's like I have a limitation and I pay someone who's not related to me to help care for me, and I eliminate the number of people who are medically trained coming to my house, we do lose the difference between formal and family care. So this effect goes away when we change the definition of formal care. But overall, what I think we are finding is that after accounting for endogeneity, formal care only leads to worse mental health outcomes compared to family care. But like I said, that's very sensitive to the definition. So I think the takeaway is really that receiving both family and formal care is better for both self-reported physical health and mental health compared to receiving family care only. And in the US, we have significant barriers on accessing formal care, as well as barriers in supporting family care. And so if we really want to think about how to get, if you believe this result and you think that this might be something that we might want to achieve and letting people get this type of care at home, we really need to be thinking about how we can sort of minimize some of the barriers we have for accessing formal care and supporting family care. And with that, that is the topic of Courtney's talk on how to support family caregivers. So I will stop sharing and turn the mic over.
Thank you very much, Norma.
Okay, thanks so much, Norma. Yes, we're very parallel, but I'm going to kind of zoom out from this very specific look where Norma laid out the challenges and importance of really taking causal approaches and understanding the economics of informal care, and queued me up for talking about policies. I'm going to talk about the scope of informal care, focusing on OECD countries, the economic costs of informal care, more in the broader literature, not just looking at care recipient outcomes, and talk about some of the policies that are showing promise and that could be expanded to really support this combined care team in the home. Okay, I saw that one of my dear colleagues from the Rosalind Carter Institute is on today, but I wanted to kick us off with this amazing quote from Mrs. Rosalind Carter, who, as the former First Lady, she passed away this year, but she devoted her post-White House life to supporting caregivers with a special passion for mental health, caregiving and mental health, and also military caregiving. And I think this just sums up why we all should care about caregiving. I like to say that there are only four kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So this is affecting all of us. Either it has or it will. And clearly, family caregiving, as Norma showed in that descriptive first slide of hers, that caregiving remains a very important and the modal source of long-term care in people's homes in the US and across the world. It's huge. It's a huge proportion. So this is a graph showing the percent among the population of adults age 50 and older who provide any informal care. And in OECD overall, around 13% of people are providing care. And it varies by country, of course, the lowest in Latvia and the highest rate in Belgium. It also shows care intensity varies. That yellow, dark gold shows the percentage of people who are in daily caregiving compared to the lighter yellow that shows people engaged in weekly caregiving. And really, it just shows there's a lot of variety across the countries and in the intensity of care people provide. Just of note, this is just descriptive, of course, but it shows that fewer people provide daily care in the countries that have a stronger formal long-term care system, which suggests that there's a trade-off between these sources of care, family or unpaid care. What I'm using is the UK term today of informal care. I'm going to try to informal carers, but you know, this is just correlational, but that certainly is also supported in the causal literature that informal and formal home care can be substitutes for each other. Additionally, not only is informal care filling a critical gap, the burden is predominantly impacting women. Again, across these 25 OECD countries, almost 2/3 of family caregivers are women. And this also varies across the OECD countries. 80% of caregivers are women in Hungary compared to just under 40% in Switzerland. Again, this is sort of repeating some of the things that Norma said, but although we've worried very much about all of these bulleted factors that may be reducing the supply of informal care, there's increasing, and that's a big worry because of the increasing demand, showing that, you know, right now we have in the OECD countries on average 18% of all the population is 65 and above, and that's expected to increase to around 27% in 2050. So there's going to be increased demand for care because of the changing age profile, but lots of reasons why we are concerned that this supply of family and unpaid care won't keep up. Although I have to say, anecdotally and also in our descriptive work, we have found that people still are stepping up and doing this care. So I would like to see more work in that. Okay. I want to talk a little bit about the causal effects of informal care on outcomes that the public or private initiatives could address. And while the descriptive work's been truly foundational in this area, I'm really focusing on the health economics causal literature because of this. It's most useful for policy, and we want to have accurate understanding of really the treatment being the family caregiving on the outcomes rather than the reverse. In general, this the average effect of family caregiving on care recipients has been positive. This is notified by the green on this slide as good. And there have been better health outcomes, but as Norma described, there's a surprisingly little literature on the patient or the care recipient's outcomes. She talked about the benefits in self-rated health. Well, we have past papers on self-rated health and bed sores and this reduction in depressive symptoms. But this is an area where we need more evidence, clearly. There's also cost savings. There's a larger body of literature on the causal effect of informal care on cost savings. And this is pretty well established. It comes from the reduced utilization that family caregivers afford, such as delaying or reducing nursing home use or having reduced health system spending in general. Let's move though to the caregiver outcomes, and that's really what I'm going to focus on in terms of thinking about policy remedies. The average effects on caregivers are generally found to be poor in the causal literature. Then these are the biggest number of studies and the strongest evidence base is in economic status. So worse economic status in general, this is coming primarily through labor market effects, and those are concentrated among women. Women in particular are having the ones experiencing lower wages. They're retiring too early, they're quitting work and cannot re-enter the labor force if they want to. And then kind of more broadly, men and women are facing high out-of-pocket costs as caregivers. Secondly, it's well established that there's worse health outcomes. This has been focused on caregiver depression. Also, so kind of this mix of mental health and physical health, like Norma described for the care recipients. And that whereas caregivers have been described to delay their own treatment, there's kind of causal evidence that they're overall seeking more care, possibly due to the worse health that arises from the caregiving. So higher utilization. And one positive note that I don't show on this slide is that there's some evidence that if you do become the caregiver in the family and your family gives intragenerational transfers, that you as a caregiver are going to be more likely to get a cash transfer. So some notion that this being the caregiver can protect your inheritance. But again, that's a very selective group of families who are leaving inheritances potentially and giving economic transfers or financial transfers to their kids. I want to point out the heterogeneous effects of informal care because this is where the evidence needs to grow, and there's certainly work in this area, but I feel like this is a great area where we can expand. Again, work joint with Norma and Megan Skyra in looking at sort of subgroups of people. I already made the case that females are bearing the brunt of the labor market negative effects with reduced wages. Other work by Norma and colleagues that found that if the type of recipient really matters, that the welfare losses to the caregivers are greater if the care recipient has memory impairment and functional limitations or any combination of those two things. So Additionally, we have worked and found in the causal literature, a causal paper, that intensive caregivers fare worse in terms of their relationship quality with their care recipient compared to non-intensive caregivers, and in a descriptive study that intensive caregivers are more likely to quit work compared to non-intensive caregivers, which is a very logical finding, right? Like, it's hard to juggle if you're an intensive caregiver. So that's a group to really be thinking about as people keep looking at heterogeneous effects. Similarly, depressed caregivers have more missed days at work if they remain on the job than those who are not depressed. So really important to think about these heterogeneous effects, because we know then we can target policy remedies based on those who fare worse. I want to spend a couple minutes on this slide because a lot of the work in the US, and also I think in a lot of countries that have kind of the parent HRS type study, health and retirement studies, have been only able to look at work outcomes and economic outcomes among those caregivers who are 50 and above because of the design of these household surveys. And so I want to highlight a paper that used a different data source, the SIP data in the US, and by Maestas, Messel, and Truskanowski. And this is a really nice paper because they have the whole age distribution of workers from 18 and above. And they look at both earnings effects and employment effects over time. They use matching to try to get at this causal effect of caregiving on earnings and employment. What they find is that they have a really successful matching because the trends in earnings is almost identical. Similarly, the trends in work behaviors are really identical in that era, up to 13 years or so before they start their caregiving spell. And then after they start caregiving, you see immediate drops in earnings and immediate drops in labor force participation on the magnitude of about, let me get this straight, about 4 to 6% drop in earnings and about 3 and 4% drop in labor force participation in the immediate year after the caregiving spell begins. And they are able to look out up to 10 years to understand what are the long-term impacts of taking on that caregiving spell. And what they find is that caregivers remained below the comparison group in earnings by about $2,000 for at least the next 9 years. And they never returned to match the comparison group in the observable period, so up to 10 years. There's heterogeneity in this paper as well. They find actually the first kind of health econ and caregiving paper that there's some benefits to women compared to men. What female caregivers' earnings and employment recover faster than male caregivers. They do, when you look at a subgroup of women, they return to that pre-caregiving level, and there are no differences over time with the comparison group. However, women who begin their caregiving at younger ages experience larger earnings and employment changes than women who start caregiving at older ages. So this is a really nice paper, and it uses a different data source that I know will be getting a lot more use in terms of looking at younger caregiver outcomes. Let me switch to, in the few minutes I have left, to policies. I want to highlight that policies really vary across the OECD and are I would say weakest in the US, or quite weak in the US, and that indirect policies and direct policies have been evaluated for caregivers. And the point here is that direct policies clearly are important, but indirect policies we need to look at too, especially when there are a few supports that are directly supporting caregivers. So in the OECD, about 2/3 of countries provide cash benefits to family caregivers, cash for care allowances that can be used to pay for care, to pay for caregivers. They also have, 2/3 of these countries may have paid leave for family caregivers. But in the US, we don't have cash benefits at all for caregivers, and there are some limited cash for care allowances, such as in the Medicaid waiver programs that are the insurance mechanism, public insurance mechanism for low-income Americans, or for caregivers of veterans who use the VA system of care, Veterans Affairs system of care. Similarly, in the US, training is very ad hoc. Very few people report receiving training, and less than a third report receiving any caregiver services or supports. And then paid family leave in the US is also very spotty, with states taking up the charge. About 14 states now offer state paid family leave where you can cover a caregiving spell between 6 and 8 weeks or so. Or you can take unpaid family leave, which many people can't take. They can't afford it. So those are some of the direct policies. Indirect policies, though, we need to look at because they are being found to affect the well-being and supply of informal care. So healthcare reform in the US has been shown to increase the informal care supply. That's work that I've done joint with Nakdao and Yang Wang, and also work joint with Joan Costi-Font and Nilesh Raut. We found that healthcare reform in the US also improved the mental health of spousal caregivers. There's emerging initiatives by firms to offer more flexible work. This is accelerated in the pandemic, but really important to keep in mind as multi-sector approaches to supporting caregivers. Increasing long-term care insurance coverage benefits caregivers, and I'll talk about that in the next slide. And then increasing home health care benefits, as Norma pointed out, could really improve caregivers and care recipients by emphasizing easier labor force participation by the caregivers and better health outcomes of the care recipients. So just a really brief example, state paid family leave has been shown to also, as a direct policy in the US, increase the supply of informal care overall. Again, this is being driven by females and those who are co-residing with care recipients. Additionally, the state family leave has kind of significantly but modestly increased labor force participation for females and decreased social welfare spending with no changes in wages or hours of care overall. And there's another paper by Courtney Coyle and colleagues who have found increases in labor force participation, although they haven't looked at informal care supply. So this is a note kind of important to think about as more states are taking on state paid family leave. Indirect policy example, formal home care access improves caregiver outcomes, not just the care recipients, as Norma highlighted in her talk. So thinking about increasing formal care access and affordability can make adult children whose parents are needing care less likely to drop out of the labor force, from some evidence from Schmitz and Westphal and Karen Chen. And also Norma and Gopi and my work has found that universal long-term care coverage or increasing private long-term care coverage frees up the adult children whose parents purchased a policy so that they are more likely to be working full-time or working in the labor markets. Okay, I think I'm going to run out of time, but these are just some gaps where we could move next. We don't have a lot of evidence. This is a map of kind of where the intervention's really focusing to support caregivers. And it shows that the bulk of them are on how kind of therapeutic and educational interventions help mental health and burden, but we have very little evidence in how system level interventions affect financial things like financial information advice interventions or pain management interventions or physical skills training on outcomes. So that's an area we can move. And finally, I just want to highlight that I'm very convinced that a multi-level policy or practice solutions are needed to best support caregivers and support this care team that is emerging as so important, both formal care and informal care combined. So with that, I'll leave it, but I think just wanted to point out that not just policy that I just talked about, but there's a role for research, there's a role for public health systems and employers to really solve this problem of how to best support the default and important source of long-term care in people's homes across the world.
Thank you very much, Courtney. Excellent. So we have got almost 15 minutes for question and answers and then discussions. So may I ask if you have got any question, you can raise your hand or just use the chat function to post your question. So Adelina, please.
I was very quick. So I was interested in on the first, well, both presentations were amazing, by the way, and this is really updating me on the key references to look at when we make the case for care and for supporting carers. I think it's a fantastic two presentations. And on the first one, Norma, I had a question. It's a bit on the interpretation of this finding that only formal care is not, has a negative effect on positive effect and how people feel. I mean, there's obviously always this tricky thing of whether this is to do with not having much people around you, and that's why you're not getting care, and maybe there's a loneliness that maybe the services are not being able to meet. And I think in many countries, I don't know so well in the US, what we're seeing is that home care becomes more and more task focused and very short. So in the UK, we're having really short visits where you literally just get some of your personal care, like one or two physical tasks done, and then they're out of the door and there's no time for the discussion, for a chat, for a bit of informal interaction. And I just wondered if that might be behind what you're finding, or what is your thinking of why you're saying this. Thank you.
Yeah, I mean, I think that's an excellent point, that like whether it's unmet needs or, sort of just socialization overall or lack of socialization overall that we're picking up. We haven't dug into that ourselves, but the fact that it sort of, and partly because, if you change the definition of formal care, it kind of goes away. And so we're kind of like, well, like maybe it is like, it's very a nuanced story. And so if I wanted to write a check on what our results are, I would focus on the sort of the benefits of having both, as opposed to the differences between formal and family care. Because I think in the family care part, you also have like, we don't know. We have great measures of what is actually happening, and whether or not the family is trained to do the care that is necessary. And so you probably have sort of limitations of both sides of receiving one or the other. But I think your point of like, this is really fast. Most people in the US are getting their home health care, formal home health care from a Medicaid program, which has had workforce issues long before COVID and only exacerbated by COVID. I think is a very, very good point.
And there's always not a choice on whether you're having formal care or not. It may not be available to you. So for those people, then there is obviously something that isn't being met, I think.
Okay, thank you, Norma and Adelina. We have got a question in chat box. So yeah, a link to actually Norma's paper. And then, yeah, a question for have any presenters see any data on benefits of family caregiver training? So I think Courtney already posted a response there. So we have got another question about the first paper. So Norma, do you have any information on the hours of informal or formal care?
We have limited information on the hours. So we have self-reported hours, but it's not always like, over the last 2 years, right? They do a limited window on how often what you're measuring the hours for. And so we've used it in the past to sort of measure intensive versus non-intensive, but we were hesitant to sort of really rely on how many hours did you provide. I think it's in the last week or last month, something like that, as a really good measure of how much was provided over the last 2 years in between the intervals that we're looking at the care provision and the outcomes.
So thank you, Courtney, for sharing another paper thing. Yeah. So any other question? Please raise your hand. So I have got a question myself, Norma, for that actually econometric model that you use. Did you control also for that duration of the care actually that they provided, when assessing the mental health outcomes? Did you control for the duration of care? Like, was it like 1 year, 1 month or more?
So we look at the answers of the care that's been provided in time T, and then that we do outcomes 2 years later. Is that what you're asking? We don't control for sort of I've been receiving informal care for 10 years or anything like that. It's
just the last 2 years.
Yeah.
For everyone.
Yeah.
Yeah. So I was just wondering if someone was, just receiving care for more than 2 years, or with it, like struggling with a specific condition. So I just thinking, how it could affect actually that mental health outcomes specifically. So
yeah, we haven't looked at the longer patterns, because also the patterns change over time, right? So this year these last 2 years I could be receiving both. The prior 2 years I was receiving only family care, right? But we didn't look at the trajectory like that.
Yeah, perfect. So I see some hands raised there. Greg, please go ahead.
Yeah, I was wondering with the type of caregiver, particularly contrasting the spouse with adult child or other family member. It's the spouse is probably more likely to live in the home. I mean, there are a lot of have at least for older people, more functional problems themselves. I'm wondering what differences you might have found there. Did you do some subgroup analyses?
We did. We looked just at people who aren't married, who don't have spouses. What I remember is that basically the average treatment effects actually didn't change all that much when we eliminated people with spouses, because there's a lot going on with spouses, whether or not the caregiving is measured in the same way, whether or not they're co-resident versus not. We didn't want to control for co-residents per se, because that in itself could be endogenous to the health and the health outcomes of the person living with disabilities. And so the only thing we did was run 2 different samples, and we found very similar results.
Thank you. Olina, please.
Hi, Norma and Courtney. Good to see you, and wonderful work that you presented. Thank you, organizers. I might have missed, but just wanted to clarify this negative effect on one of the outcomes from the formal care only. Have you controlled for like loneliness, or like this pathway basically? If that is kind of the reason why, compared to people who get only informal care, or so basically, is it kind of very formal care that they are receiving? Someone came, prepared dinner, gave it, left. As opposed to, some communication, some companionship in addition to that.
Yeah, we know very little about what is actually being provided. We just know that someone is helping them prepare meals, say, or someone is that they pay, or someone is helping them with transportation. We don't control for loneliness, although I think that could be an interesting outcome in and of itself. Sort of self-reported loneliness seems like a very worthwhile outcome. That gets also at sort of Adelina's point too. Like, is that the mechanism in which this is all happening?
Thank you. So we have got 5 minutes left actually there. Cassandra, please, if you want to just kick off the discussions.
Okay, so my question was, and I'm not sure whether you covered it, was about different types of care. So we might say that not all care is created equally, or not all care is equal. So I know that you had Medicaid care and private care, and one of the things that we think of is, well, if care is being bought privately, then it may be less task orientated, because the person purchasing the care, be it the client or the family member, can specify the tasks in a different way and pay, potentially for more hours, etc. Did you compare those two? Did you have any other measures in addition to that might look at different types of different sort of types of care to some extent.
Yeah, I don't think we did. So we don't know if somebody is paid. We don't know technically if they're paid by Medicaid or by another source. But we could do a sample cut on Medicaid beneficiaries versus those who aren't. And I don't think we did, I'm embarrassed to say. But that's a great suggestion.
That would be interesting.
Yeah, that's a great suggestion.
Great. Cassandra, please.
Well, we've got 3 minutes left before the end of the webinar. So actually, a question came to mind that I want to ask both Norma and Courtney. So I hope everyone in mind, and if you do want to jump in with your views, please, by all means. So my question is, so Norma, based on your presentation, we see that having a mixture of informal and formal care has a positive effect on patient outcomes, user outcomes. But then Courtney, you also show on the other side that we see a lot of negative impacts also of informal care. When it comes to policymaking and showing this evidence base, how do we consolidate the two and how do we link them? Yeah, if you have any views, also if anybody else has any ideas, please jump in. I think it's a crucial thing to consider when it comes to policymaking, how we balance the views and the preferences of everybody involved in the outcomes.
Yeah, I mean, I think in the US, we just don't have a system. And so we have what we have, but it is not, I would not call it, we don't have a care delivery system, really. We don't have an insurance system, really. It's just kind of been left to every family to figure it out. So I think it's just really hard. Any change sort of towards helping with access or providing support for family caregivers in the US, I think is actually a step in the right direction. But we would really need to take a much more comprehensive look if we wanted to move the needle on financing care, family and informal, helping family members provide the care, as well as employment, as Courtney highlighted. We don't have paid leave in the US. It's very hard to be a family caregiver when you don't have different options in your workplace. And so I think a really comprehensive look in the US, and hopefully, a lot of the work that you guys have been doing within the long-term care network, we can look to other examples, and that's what I do, and looking at what other countries are doing and helping set up a system, because like I said, we just really don't even have one set up in my mind.
I think that's well said, and that really the push is to expand family caregiver supports in the US. It's the only policy traction I see. And that's just not going to be enough. We need to support both, expanding home health care and expanding supports for caregivers, like Norma said. Otherwise, we're going to keep seeing the negative outcomes we see.
And thank you, everyone, for joining us today. And thank you very much, Norma and Courtney, for these great presentations. Looking forward to see you all in our next webinars. Thank you.